This lecture is designed to give the general practice doctor an idea of what SS White is doing in the endodontic area and why that involvement is special and the philosophies behind that. And the idea is to create better outcomes for the patients through modern endodontic concepts. We're going to start this lecture looking at a tooth graveyard. This is a drawer of teeth that David Clark found one day, and this was an epiphany for him because he looked at this drawer of teeth and he asked himself, why had all these teeth failed? And the fundamental answer to that question has led him to where we are today. And our purpose in dentistry is to keep people's mouths functional. To do that, we need to repair and prevent dental disease and retain many teeth as we can in the face of that. The premise of this lecture is about conservation of dentin during endodontics and restorative procedures and the importance that conservation becomes as far as increasing tooth strength and subsequently decreasing the loss of teeth due to fracture. This is all about not compromising our ability to do effective endodontics, but at the same time conserving dentin as much as possible. So the lecture is about dentin conservation. More dentin equals stronger teeth. We need to say a word about SS White's involvement. The conservation changes that we're talking about here were developed by clinical dentists in the face of failures that they felt shouldn't have failed. And they've developed concepts and tools and armamentarium that are necessary to fulfill the concepts they've developed. And we as clinicians are very fortunate that SS White saw the wisdom of these ideas and was willing to step up and produce the tools necessary to help us achieve the clinical results we want. And they are to be commended for doing that. Many dental companies do not have that level of involvement. This is a picture of myself. I'm an endodontist in San Leandro. I'm in private practice. I lecture extensively, and the quote that I came up with here is that all dentin is not created equal. The endoguide burrs and V-taper instruments are at the heart of this conservation of the perisurgical dentin is an important concept for us to understand. We have many misunderstandings, or what I call legacy ideas. These are ideas that at one point in time had validity, but today don't because the underlying technology has changed, but they still exist just for historical reasons, inertia reasons. And one of the biggest ones of those we've got is a misconception and a misunderstanding of what tooth anatomy is at its fine details. And the reason we have that misunderstanding is the way we view teeth. If you look at either a photograph of a tooth as we see here, or an x-ray of a tooth that we see here, they both give us a picture of what this tooth is like. From that, we develop a mental model of what the teeth are like. And from that mental model, we make decisions based on what we're going to do with that tooth from a restorative and endodontic standpoint. Unfortunately, the way we view these are from classically two-dimensional pictures. And the reason we get confused here is that if you take a tooth, take a cross-section of it, and you look at it and sort of draw the outside form of it, we're actually looking at, on these two-dimensional views, the outside form of the tooth, not the fine details, especially where there are concavities. If we track the concavities, you can see that the teeth are significantly narrower and have a straighter taper than you would assume looking at the more gross two-dimensional pictures of us. This leads us to a mental model of the tooth that is inaccurate. We think it's more robust than it is. We think there's more taper than there is there. And this incorrect model drives us to decisions and treatment selections and instrument selections that is inaccurate. So our mental models drive our decisions, But those mental models, because of the way we've classically viewed these teeth, is inaccurate. The reality is there is less dentin than we think. There is less taper of the roots than we think. There are more concavities. In fact, they're ubiquitous. Almost every tooth in the mouth, including some people who don't think have concavities, in fact do have concavities. So there's less taper, more concavities. This has led us to legacy errors, and it's these legacy errors that have created the problems for us. This is an example of a transparent lower molar. You can see that there is deep concavities both on the mesial and distal roots in the furcation area. These are not obvious on radiographs. They're only obvious if you do three-dimensional imaging or actually look at a live tooth. The cone beam CT technology has made this more viewable, visible for people, and has been a great adjunct in getting people's awareness of tooth anatomy improved. These concavities make the teeth much thinner, and that means there's less dentin to work with and there's less strength. This is an illustration from a textbook, John Ingles Endodontics. It shows classic access preps. These are both grossly over-enlarged. Another plate of an upper anterior. Again, these are gross over-enlargements, and this is unnecessary and is not appropriate the way we do things now. A clinical example of two teeth that were prepped, accessed underneath these kinds of protocols, and using burrs that were too big, using round burrs that were too big, and you can see the gross amount of dentin that was removed and almost perforations. This is the mesial root of an extracted lower first molar with a small spicle of bone attached that was scanned in a high-resolution research CT scanner. And it was done at the request of the endodontist who did this tooth to check the effectiveness of the endodontics that was performed on it. You'll notice that the tooth has a middle mesial canal, which occurs maybe 13 to 15% of the time in lower first molar mesial roots. You will also note the dramatic concavity on the furcal side of the root, and also a concavity on the mesial side of the root. More telling is the amount of transportation of the canal toward this furcation and the size of the access prep that was created in this tooth by the instance that were used. This is a perforation of the lateral wall of this tooth, and it's because of the file system that was used. It's a file system that, in my estimation, has a design defect in it and creates spaces that are too big for the roots that these systems are being used in. Another tooth, this was in an article published by a very well-known endodontist on how to remove instruments, and you'll notice that his access prep is grossly over-enlarged, and this is put out as an appropriate access prep, and it actually disrespects the anatomy to the place where if you could put a crown prep on this tooth, you have very little dentin left to support the endodontics or the restoration, and you are setting yourself up for a failure from tooth fracture. This is a drawing I did about 30 years ago, and it was designed to illustrate the fact that the current technology at that point in time, the current recommendations at that point in time, were to remove this triangle of dentin down at the bottom of the pulp chamber to give us more straight line access to the canal systems. This was designed specifically to create a canal system as straight as possible. The reason that was necessary was that the instruments we used were stiff stainless steel hand instruments, and they did not go around corners very well. This is a legacy idea that unfortunately is still being taught, one that I rejected a long time ago, probably 15 years ago. And it can be rejected because of the instruments that we use today. So the conservation is sacrificing this access because of the limitations of the instrument designs that we had at the time. So the solution to this abuse of the dentin is to adopt modern endodontic concepts. And those concepts include, first, respect for the anatomy of the tooth and understanding what it is. Secondly, conservation of the structural dentin, which is designed in as we do our work. And thirdly, the use of modern instruments that conserve dentin and help us go around corners better. To give you an example, this is an old school drawing that I just showed you. If we look at the new school variation of this drawing, you can see that the pulp chamber is much, much smaller, and we have conserved a substantial amount of dentin both in the pulp chamber area and in the upper canal systems. The old school idea was to straighten out the canals as much as possible. The new school idea is that we project the upper canal onto the occlusal surface of the tooth. That defines our occlusal opening, and we try and maintain the natural width of the pulp chamber, and we find the canals without blowing out the inside of the tooth. This conserves the paracervical dentin. This is possible because we have newer instrument designs that have smaller cervical diameters, and they're made from stronger, more flexible metals that will go around curves better in the canal systems. So, let's look at a conservative access prep design. This is an orifice-directed design, and that's the language we're using. There are two areas you need to be concerned about. The first is the pericervical area, which is the area around the cemento-enamel junction, above that, and down into the upper root structure. The occlusal table is not as important because it doesn't have the importance to the structural integrity of the tooth. Now, there's actually two separate solutions that you need to be aware of here. The first is the pulp chamber area, and the second is the upper canal area. The pulp chamber is conserved by using appropriate burrs, appropriate craftsmanship, and designing the conservation in. Otherwise, we don't widen the tooth out any more than we have to find our endodontic objectives. The coronal part of the canal conservation is determined by the file system that you use. And if you select the wrong file system that's too big, it will automatically take away too much dentin up there. If you select the appropriate file system, and we believe the V-taper is the most appropriate file system, you will automatically, because of that choice, get the kind of conservative preparation design that you desire. So, the conservative access prep, again, is orifice directed. In a molar, you might take and do your initial access into the upper part of the occlusal table, widening it out, taking your best guess of where that's going to be, staying slightly conservative, and in fact flaring it a little bit to give yourself better visibility. Once you get oriented, you're going to go down, find the pulp chamber, minimally widen that, and then smooth that whole area out so it flows gently into the occlusal table. You're going to find the canals and then start your cleaning and shaping. You may end up using an EG burr to smooth out the junction between the upper canal system. The occlusal outline in this prep is dictated by the canal projections off of the upper part of the canals. And it's going to vary from tooth to tooth depending on what the internal shape of the tooth looks like. The pulp chamber dimensions are designed in and intentionally left small by just good craftsmanship. And the file choice determines the amount of dentin that's removed in the upper part of the canal. And we feel that the SS White instruments are particularly good for this. They're designed to conserve dentin in that area. This is a balancing act between conservation of dentin and giving yourself enough access to effectively do the endodontic procedure. You still have to find the canals, find the whole canal system, you have to shape that canal system and debride it, you have to irrigate it, and you have to obturate it. And you need a certain amount of room to do that. But that can all be effectively accomplished in a much more conservative prep than is standard today. This is the V-taper file system, and it is designed specifically to support the idea of dentin conservation. And this is the only file system on the market that is designed to do that. It has a number of features we need to talk about. The first is it's a multi-taper design. And what that means is we're going to bring up a tooth here, and I've actually put a profile on the back of it that's a magnification of the actual profile. This blue and white bar graph is the diameter of the tooth at different locations magnified by 5 times, and it gives you a clearer idea of what the profile of the instrument is. You'll notice that it has a steeper profile at the apex. This is both for control of gutta percha during obturation and to give you a little bit deeper shape so you get more effective irrigation at the apex. But as you come up the file toward the upper part, you'll notice that it ends up being actually parallel. So what it does is it transitions into a very conservative instrument which is wide enough to work through and give you access to the apex, but in fact is conserving of the dentin in the upper part of the canal. And this is a purposeful design designed in to give us the conservation that we're after. You'll notice a juxtaposition of the V-taper instrument against a ProTaper F2. These are the same apical size. They're the same taper at the bottom 3 millimeters. They're both 25 diameters and 0.6 tapers, but you'll notice a substantially bigger upper diameter on the ProTaper instrument. It's 1.2 millimeters versus 0.8 millimeters for the V-taper instruments. My opinion is that that's big upper diameter on the ProTaper instrument is actually a design defect, and it was put in place because the people that designed it didn't really understand the anatomy of the teeth that they were working on. And you blow out way too much dentin with that instrument. So the V-taper instruments has a profile that is designed to match the profile of a typical root form, and it does in fact do that and conserve the dentin. The upper file profile is a significant and important advantage of this system, and it's a designed-in safety feature to keep you from taking away too much dentin in teeth. Secondly, it has a very effective and efficient flute design. This is a zero rake angle flute. We call it a parabolic curve. It has metal behind it to give it strength. The edge is the furthest thing out there, so it cuts effectively. It doesn't have a land which gets in the way of cutting ability. It's not negative rake like the triangular shaped instruments, which don't cut very effectively. And this is the most efficient cutting instrument on the market. And because of that, it feels different. It actually doesn't require hardly any apical pressure to actually get it to cut. And so what you do is you just sort of walk it down the canal rather than having to push on it to make it cut. And it takes a little while to get used to that. And the first time people use them, they get a little disconcerted about that, but it's a quick learning curve. So we recommend light apical pressure. We also recommend that you use a slower speed. So we're going to recommend you use 150 to 200 RPMs, take a 1-second cut, and then clean it. You'll notice that the core diameter of this file is fairly large, and that is a safety feature because it makes the instruments very strong. The only disadvantage of a big core like this is that there's not quite as much room for debris around the file system, so they do need to be cleaned off fairly frequently. So our treatment recommendation is 150 to 200 RPMs. Take a 1-second cut. If the instrument stops progressing apically, you take it out, you clean them, and while that sounds like a lot of work, it generally only takes 2 to 3 cuts to get to the apex of the canal. The third is the heat treating of the metal, and this has been a real improvement in these. And what it does is it makes these instruments incredibly flexible and having very, very high fatigue resistance. You can actually pre-bend these instruments and put a curve in them to give yourself a better insertion path in difficult access cases. As soon as you turn it on, it straightens out, and it doesn't bother it at all to do that. So the metal and the smaller upper diameters have made these things very flexible in the upper part of the file and allows them to go around curved canals very gracefully. This is a chart of the V-taper system, and you'll notice that the bulk of the systems are 0.6 taper instruments at the first 4 millimeters. Then they go to a 3 taper, a 2 taper, and then a 0 taper. So the last 4 millimeters of the file is actually a parallel flute. And it's that gives them the small diameters. The 0417 is kind of halfway between a real file and a glide path instrument, and it's used typically in smaller canals after you've used your 15 or 20 hand instruments to open the canal up just enough that your 20s and 25s will go down. They come from a 20, 25, 30, 35, 40, 45, 50 tip size. And you'll notice even in the 50, which is a fairly good sized tipped instrument, the D12, D16 diameter is less than 1 millimeter. So these are all small instruments at the upper end of the file. Now, we added 3 more instruments to this line. The first is a 2207, and that instrument is just slightly bigger than the 0620 and is an ideal instrument for lower molar mesial roots that are on a big molar, buccal roots and upper molars, and that type of thing. The other 2 we added were 2 08 instruments, an 0825 and an 0830, and these are designed to give you a little bit steeper taper right at the apex on canals that are bigger, maybe lower bicuspids, central, that type of thing. So between all of these instruments, you can generally find an instrument that will give you a final shape that mimics the profile of the tooth root that you're working on. Technique-wise, we recommend that once you've accessed the tooth, that you establish patency with hand instruments if the tooth is at all calcified. You need to go up to at least a 15, possibly a 20, before you go into the rotary instruments. Once you've done that, you go to your 1704. You need a loose glide path to start that. The 1704 widens that out, smooths it out, and it makes the 2006 and the files above that very graceful. So you step back from the 17 to the 6 to the 25. Again, all run at low RPMs, 200 with light pressure and frequent cleaning. Torque, we recommend setting at 100%. You should be inspecting these instruments, not depending on the handpiece to reverse torque these. And the apical size is adjusted by the size of the canal. Some people like to take the upper canal out of the cleaning and shaping early in the process, and they will use something like a 25 or 3006 in the upper 3, 4, 5 millimeters of the canal just to open it up a little bit, so they don't have to worry about cutting dentin from there, while at the same time they're cutting dentin from the apex. I personally do this. I know people that don't. It's a personal choice type of thing. But I like to clean the upper part of the tooth out, kind of where it'll end up being finished before I actually go down and get the apical part cleaned out. Now, if you run into calcified teeth, there are 3 scenarios that you will run into. The first is the loose scenario, and this is basically a tooth that's not calcified. And in those teeth, once you've established with a hand instrument that you have a patent canal there, you can go to your rotary instruments immediately and do your normal cleaning and shaping. You apically gauge the tooth to figure out how big it is by taking a hand instrument and just gently placing it at the apex and seeing how big of a file will go in place. You're also looking at the dentinal debris on the instrument to give you an idea of where the instrument is cutting. And you then go to your fill when you feel like you're actually cutting dentin, and depending on the size of the final instrument you use that size gutta percha for it. If you have to go above a size 50, you're looking at a custom cone, and that's a whole different ball game, but that's uncommon. Now, if you get into a tight canal, and I would define this as a canal that has actually canals there, but it's got a calcified pulp chamber, and you have a little bit of difficulty getting into those. You start out with a 10 file, and you go through your 10, 15, 20 hand instruments, and using a watch wind technique until you get the canal open to either a loose 15 or a 20 hand instrument. Then you're back to the loose canal, and you're going into your rotary instruments. If you have a really tight canal, then you have to actually establish a glide path for the glide path instruments, and these can be very tough. It can take multiple passes with EDTA and very small instruments, 6s and 8s and 10s, to just get yourself opened up enough that you can actually get a 10 file to the apex. Once you've done that, you can work your hand instruments some more, go to a 15, and now you're to the tight canal, and eventually you go to the loose canal. So how much hand instrumentation you need to do depends on how tight and how calcified this is going in. And basically what you're doing with the hand instruments is you're establishing a glide path, and you absolutely have to have a reasonably loose glide path to use the rotary instruments. They do not end cut. You have to have a path to actually follow. So you have to have the canal opened up to a loose 15 at the minimum before you put a 17 in there. Many people go to a 20 just to make sure that they don't get hung up. So let's talk about some design considerations here. On upper maxillary teeth, we are changing what we think the paradigm of this should be. And we have to give credit to David Clark and John Cotomy for some of these design considerations. But we put in a small notch right at the incisal edge that gives us a guide to where we think the projection of the canal would be. What we're striving for here is as straight line access as we can get. And so we put that small notch in, then we go into the lingual of the tooth, lining up as effectively as we can, and go down, hit the canal, and then open it up with the instruments. So what you end up with is a very long but narrow cleaning and shaping that's straight line and ends up involving this incisal edge a little bit. Now, that can be repaired with restorative materials, modern composite restorative materials, very effectively. The other issue we've got here is that you need to clean out these pulp horns, and there's a couple of ways of doing that. You can take an E.G. burr in there. You can put small back angle explorers in there. And the reason you need to do that is there's debris in those pulp horns that can stain the tooth down the line, and it'll turn dark. If those are cleaned out adequately, you won't have that problem. So here's a case using an EG burr with some slight angulation of the x-rays. These are very good burrs for locating canals because the triangular shape gives you better visibility, and if you're shooting x-rays with this burr in place, it gives you a very sharp point to where you're at. So what we're trying to do here is do minimal accesses and conserve as much of the pericervical dentin as we can. It's a case done by Robert Core from Colorado Springs. This is a really big canal. This person lost the pulp in this tooth when they were fairly young. But even at the size of this, he was able to do a very effective endodontics through a relatively small access prep. And so if people tell you that you have to have a continuous taper from the apex all the way up to the occlusal surface of the tooth, that's simply not true if you know what you're doing. And you'll notice that the pulp horns in this case have been adequately restored, and this is a really good example of heads-up treatment using this new technology on a fairly big canal. It's a clinical case of a tooth that's fairly calcified. You'll notice that you can see down inside the different colors of the dentin. You can follow the dentin roadmap. EG burrs are very good at this. This is another clinical case. The notch here is the long axis access prep, but again it involves just a touch of the lingual of the incisal edge. You'll notice that you can see the remnants of the canal down deep. These EG burrs are very good for visualizing this because you can see the whole canal because of the conical shape of them. And here we are taking an x-ray to see if you're lined up correctly. The finished access prep, and this is the finished procedure. And you'll notice that this is a fairly small but really well condensed canal space. This is a great x-ray done by Tyler Boss from Colorado Springs, and it shows the difference between the traditional approach to an upper anterior and the new modern approach. And the thing to notice here is how much bigger the traditional approach is at the pericervical area, or at the CEJ, and where the tooth runs into the bone. It's almost twice as the diameter. The access through the lingual part of the tooth is much more blown out, and there's a substantially less dentin in this tooth to support a crown if you decide to crown something like this. The tooth on the right, which is the more modern conservative approach, has a fiber post in it, which will help increase the strength of that. So of these two teeth, the right hand one with the fiber post and the modern approach and the conservation, then has a much better chance of surviving in the long term. This is a lower mandibular teeth, and they have a couple of unique characteristics. If you look at the long axis of these teeth, the long axis tends to run through the buccal cusp tip, especially on the first. These crowns actually kind of tilt to the lingual, and the occlusal table is sort of tilted to the lingual. And so you have to be careful on these when you're accessing them, that you get your long axis alignment with the actual long axis alignment of the root. And the access in the occlusal is actually in either the cusp tip or very close to the cusp tip on the ridge, A couple of examples of real teeth. These are CT scans of real teeth. And you'll notice again that the occlusal tables are angled, the crowns are kind of tilted, and your accesses are very slightly curved, but they tend to be up toward the up toward the cusp tip. It's a clinical case on a calcified lower premolar that was done by John Cotomy, and you notice the location of it and the size of the opening, which is quite small. Mandibular anteriors are an interesting tooth because the incisal edge of these teeth actually is either right on the long axis or, in many times, significantly lingual to the long axis of the root. And because of that, a buccal approach to this is actually a straighter axis than a lingual approach. The lingual approach on this tooth was recommended way back in the day because the repair of the accesses was done with amalgam. And of course, if you put amalgam on a buccal of something like this, it looks terrible. So it was an aesthetic consideration to do this from the lingual. Well, we don't need to do that today. We have absolutely superb composite restorative materials, and you can do a buccal approach on one of these, and it's virtually indistinguishable from real tooth structure if you repair it correctly. So I'm a proponent of the buccal approach on probably more than half of these teeth. If you have substantial wear, which is pretty common in a lot of people, you go straight down through the middle of it. That's far and away the most conservative place to go. Case done by John Cotomy, and again, this was done with E.G. burrs and V-taper instruments. Even a small round burr is almost too big for these teeth. You have to be very careful with them. Does conservation make a difference? And that's a difficult question to answer definitively, but there are some hints at it. And this is a first paper that was published on this. It was done in Toronto. And the conclusion of this paper was, what they did was they looked at a sort of conventional access prep, and they did a conservative access prep that allowed them to find the canal systems, but probably was half the diameter of the more typical access preps. And they found that this dramatically increased the fracture resistance of the teeth in molars and premolars, not quite so much in anteriors, but in the molar teeth, these minimally accessed teeth, or conservatively accessed teeth, were almost as strong as the control teeth, which didn't have an access in them. They're going to repeat this work more broadly, and we expect the same kind of results out of it. Another bit of work was done by a friend of mine, Charles Goodacre, and he did a chapter in a book on outcomes. And this is a chapter that really has to do with fracture resistance and tooth anatomy and the selection of posts, appropriate posts for various teeth. And what he looked at was tooth anatomy, how big the teeth were, how much dent you need to have left, and what size of post that you would put in most teeth. This is a summary of the work. It's based on post preparations, not file shapes. We can translate this into file shapes because the issue is the same. He assumed that the most dentin you could take away was 1/3 the average width or diameter of the root. Now, he was very sensitive to how big these roots actually were, especially considering the concavities. Some people would argue that 1/3 is you'd be better off with just 1/4, but he took it as 1/3 of the average root length as his recommendation. And if you look at these teeth, most teeth, with the exception of the upper central, the maximum effective diameter of a post you should put in there is only 0.9 millimeters. And things like the mesial roots of lower molars, the buccal roots of upper molars, shouldn't have posts in them at all. Lower anteriors are almost too small for posts. Some teeth, like upper premolars, need custom gold cast posts sometimes. But remember this 0.9 millimeter, because that applies to most teeth. And that is 0.3 millimeters smaller than the maximum flute diameter on some of these older multi-taper instruments, but it's bigger than most of the V-taper instruments. So going back to the slide where we compared the 2506 V-taper to the ProTaper F2, you can see that the 0.9 millimeters is well within reason with a V-taper instrument, but it's substantially smaller than what you'd get using a ProTaper as your shaping instrument. So these instruments actually shape bigger than the prosthodontists recommend for post space sizes. This is a small unpublished study that I did based on clinical CT scans, and what I was trying to do was find out how much dentin I actually had to work with on the MB roots of upper first molars. And so what I did was I took clinical CT scans, found teeth that had not had endodontics done on them, and I measured the widths of the roots at the MB1 area and at the MB2 area. So this is what we're looking at. On the MB1, they averaged about 3.2 millimeters in width. And it's actually a fairly tight, there's not a lot of variation in this, surprisingly. The MB2, they averaged 2.3 millimeters. And this is at the highest part of the root while it was still a root, just before it goes into the furcation. And this is the area that gets abused by these big file diameters the most, because it's where the file is starting to get bigger. And if you look at the 1/3 size here, these are the diameters of posts that you can use in these roots. Well, the MB1's not too bad. And again, you can translate this into file sizes recommendations. But look at the MB2. We need a file there that's 0.5, 0.6 millimeters in diameter to actually safely clean this root and shape it. If you look at the chart for the ProTaper instruments and you track these diameters, you can only use the first 4, 5, 6 millimeters of the file before you start getting into diameters that are too big for an MB2 canal. If you look at the V-taper instruments, they are, the 2006 is only 0.6 millimeters and 0.64 millimeters in diameter, and it's small enough to use in that MB2 canal most of the time. This is a root form appropriate shaping done by a root form appropriate instrument, and it's actually a safety feature. It's very difficult to abuse a tooth with these instruments because the shape profiles are smaller at the upper ends, and that's an important consideration. Some cases that were done by Charles Malpin, Steve Berg, and the middle cases was done by using ProTaper instruments. You'll notice the access styles, these were, the two outside cases were done by having orifice directed, minimally opened up coronal areas, minimally opened up pulp chambers. The middle one was done by straightening up the pulp chamber, and you'll notice a dramatic difference in the amount of dent that was done and the destruction of the dent, and consequently the destruction of the tooth. This is a case that I think is actually a poster child for this new paradigm. I really like this. And it has all the features of a well-engineered access and shaping of the new endodontic paradigm. First off, the file selections ended up with shapings that were small diameter at the upper part of the canal and kept the canal centered, and this is because they used these V-taper instruments. The pulp chamber was done conservatively. The amount of widening of that chamber is minimal, but yet it was adequate to find the canals and get into the canals and meet your endodontic objectives. Because it was orifice directed, it ended up having a flared occlusal opening. And this is very typical of these preps, and it's important that you not be trying to make these occlusal openings too small. There is no conservation of restorative material principle. You can take away as much as you want. There is not any real conservation of enamel on the occlusal surface. You can take away quite a bit of that. And opening up and flaring the occlusal opening gives you much, much better access down deep, and it's an important consideration of these. So, you've got the modern idea, you have the legacy idea. The modern idea is designed with conservation in mind. The legacy idea ignored conservation. And the awareness of this conservation created different paradigms, different designs, and different instrumentation. And the question you've got to ask yourself, which of these is better for your patients? And to me, it's pretty obvious. So, what's the next step? Well, the next step is to get your feet wet, understand what's going on here, and get yourself some instrumentation and start trying this.